مودريتور دكتور وداد العبيدي، دكتور زهير السكافي، الأستاذ الدكتور بروفيسور دكتور سرمدي خوانده، دكتور غادة سلمان، دكتور سعدون سامي، بروفيسور دكتور علي كوبا please.
I'm going to slightly abbreviate the subject. This is a very peculiar subject, and I rather collected some information since we have established the fellowship in gynecological oncology in 2018. So we have been doing this fellowship for the last 5 or 6 years and graduated 3 sessions of gynecological oncologist in the medical city, Baghdad. This topic is interesting because I have practiced this for a very long time, but I collected the data that are well documented since we started this fellowship, which are about 60 patients managed in the medical city. Now, the subject, just a minute. Just a minute. Arja. The subject is cancer of the vulva. Perhaps you don't see many here. And gynecologists usually in their lifetime see only a few cases, 1 or 2, and refer to specialized centers. So what we are going to look at to study the management of those patients who present with this disease, causes, and what are the treatment guidelines and the outcomes in respect of prognosis and survival. First thing we look at this subject is the history of vulval dystrophy. It's very important that we study the history of dystrophy. Then the previous HPV infection. HPV infection has been recognized for the last 20 years that it is one of the causes of vulval cancer. Then we look at patients, their age and sexual functions. Usually this disease arises between the 5th and 6th decade of life of women and reaches the highest in their early 70s. But nowadays we're seeing patients before the age of 40, and we have patients who are seen in their 30s. And then compliance of the patient. Is the patient too old? Can she sacrifice her genital tract? Or is the patient young and looking for more active sexual or reproductive activities? Next. I'm going to show you the pathological specimen that we have encountered in the medical city, and then just to attract you to the subject, and then we go and discuss the causes, management, and the survival in this disease. This is early stage carcinoma, and it's always hidden between the labia minora and labia majora, and overlooked by the dermatologist or the general gynecologist. Aku pointer, ma adna pointer. This is the lesion. It's always overlooked because it's in the groove between the labia majora and the labia minora. And then it grows by its size and becomes more prominent. Second slide, please. This is a slide of vulval dystrophies. And you can see leukoplakia scattered around. And some of these leukoplakia, hypertrophic leukoplakia, are developing into cancer. So vulval dystrophy is, again, one of the causes of cancer of the vulva. Shortly, I'm going to talk about why cancer of the vulva increased in the last 30 years. If you look at the statistics and records of cancer of the vulva before the 80s, you see that the incidence is about 1.7 of gynecological malignancies. Nowadays, we're seeing the statistics rising successfully into 4 and even more than 4% of cancer of the genital tract in women. The causes are, first, and women are growing at an older age. And getting older, they become more hygienic on their reproductive organs. And some of them have suffered from diabetes or chronic vulval dystrophies. In the younger age group, HPV infection is a dominant cause of this disease. Second slide, please. Now, this is an excavating ulcer going inside the vagina, excavating ulcer. This is one of my patients, and it's interesting. We come to the treatment of this patient later on. Again, I want to attract you first with pictures, and then we go in the discussion. Next slide, please. That's a polypoidal growth on the labia majora, but it's hidden on the medial side of the labia majora. And dermatologists, most of these women, they go to female dermatologists because they're not in a position to expose their genitalia to specialized male gynecologists. And the dermatologists, they overlook the lesions. See how small is the lesion? How small the lesion, but this is a polypoidal cancer of the vulva. Next slide. امشي. This is an excavating hypertrophic tumor of the vulva. Is eating all the surface area of the vulva and protruding through the vagina. This is one of the patients يمكن تتذكرها رشا. Next slide, please. All right. We go on to discuss what are the factors that are important in this disease. Vulval dystrophy is a very important issue in the development of cancer of the vulva. Now, the outstanding causes is either intraepithelial neoplasia, all right, because this develops from HPV infection. Nowadays, when we have an HPV infection, we do also colposcopy for the vulva to see if there are any VIN, vulval intraepithelial neoplasia developing in the vulva. And if we see it, we take biopsy or cauterize the area if it is not very indicative. Lichen sclerosis, which is a chronic disease of vulval dystrophy, is again a cause of vulval cancer. Now, psoriasis, we have seen a case of psoriasis, which has been treated since she was 17 by the dermatologist with various creams and steroid treatments. And when she got to the age of 17, she developed squamous cell carcinoma of the vulva. And unfortunately, with vulvar resection and chemo radiation, she died at the age of 19. All right, look at this. This is a very nice slide. This is called kissing cancer of the vulva. That side went to this side. If she came earlier, the prognosis would have been much better because this is involving one side of the vulva. Although it is near the midline, we'll talk about relation of cancer of the vulva to the midline later on, but now it has transferred to the other side. This is called kissing cancer of the vulva. هذا السايد الثاني. امشي بعد. All right. This is a specimen of extended vulvectomy. A specimen of extended vulvectomy. All the vulva is removed and sent for biopsy. You can see tumor in this area. And scattered around. نازل من هنا همينة. Okay, امشي. This is the first stage we do vulvectomy. Now we're doing both incisions at the same time. We do the inguinal glands first. If the tumor is suggestive, راح أحكيلكم how it is suggestive, and then we do the vulvectomy. In the previous days when I was in UK and worked with the Stanley Way, who was the father of vulvectomy, he used to do a wide excision, the butterfly excision, called the butterfly. We will come to it. لا butterfly, he starts incising from here, cuts all this area, goes down there, turns around and removes all this area of the skin. What he achieved a far better prognosis than when the incisions were shorter and involving smaller areas of the skin. But what happened in those patients, because most of them are in the 70s and 80s, the post-operative complications from infection, from blood loss and so on, the mortality was about 15%. His post-operative mortality was 15%. But when you look at remove the post-operative and look at the survival of those patients, the ones who survived the surgery, they had the much better prognosis, even better than the prognosis of today. This means that the more area of the skin you remove, the better the prognosis. Because squamous cell carcinoma of the vulva usually spreads locally before it metastasizes to the glands and goes to distant metastasis. All right. But what is the pathology? The main pathology of the tumor is squamous cell carcinoma of the vulva. It is about 84% of the tumors. Inclusive is verrucous carcinoma. Verrucous carcinoma is a locally invasive carcinoma of the squamous carcinoma of the vulva. It occurs in the vulva more than it occurs in other parts of the body. Okay, we come to the treatment afterwards. The second in statistics is the adenocarcinoma. 8% of the patients are adenocarcinoma. And then melanoma. Nowadays, we're seeing more melanomas than adenocarcinomas. This statistics is slightly changing. And melanoma of the vulva is more aggressive than melanoma of the ocular or the pharynx. I don't know why, because this area is more preventive for carcinoma. Other rare tumors, the Bartholin gland and mixed mesodermal tumors, we have seen one case of mixed mesodermal. And then we come to sarcomas. Recently, we have published a paper, Russia was a paper about sarcoma, dermatofibrosarcoma of the vulva. Okay. Key points in the pathology. We want to look at the pathology and try to involve this in the treatment and in the prognosis. Squamous cell carcinoma is the most common histology in vulval cancer. And luckily it is the most common because it's the mildest of all, followed by melanoma and adenocarcinoma. Melanoma and adenocarcinoma is more aggressive in the vulval area than squamous cell carcinoma. We look at it when we take a biopsy, look at the level of invasion into the dermis. It's measured from the epithelial junction of the most superficial dermal papillae to the deepest point of invasion, If the invasion is more than 1 millimeter in the dermis, then this is an indication that we have to go for the inguinal glands because it means that cancer is already spreading. We also look at the lymphovascular spaces. Figo staging has changed to reflect metastatic spread patterns that emphasize the prognostic significance of the number and morphology of nodal metastasis.
Sorry, Dr.
From
Samad,
70s,
you have 4 minutes to go.
Edna, why about it? I'm sorry.
4 minutes.
Okay. This is a very important subject. You rarely see somebody talking about it.
We'll deduct from their time.
All right, imshi, I'm trying to be quick. Okay, what is important in this? I will abbreviate this. Stage 1 and 2, which is a local tumor in the vulva. When it goes to stage 3, there is nodal involvement. When inguinal glands, sentinel glands are involved, the prognosis changes dramatically. Stage 1 and 2 survival is over 80%. In good hands, surgical hands, and chemoradiation, is more than 80%. It reaches about 85%. But when it goes to the glands, it drops to 40%. So there's a very vast difference between stage 1 and 2 and stage 3, okay? So we try to do our best in those stages to improve the survival. And if it goes to stage 3, we will have to involve the inguinal and iliofemoral glands in the dissection of the tumor. امشي أخوي. Diagnostic key points. We have to look how we reach the diagnosis before we start our treatment. Vulval cancer often presents with a pruritic or painful lesion, and this is very much overlooked by the dermatologist or the general gynecologist. Through our general gynecologist, he prescribes steroids, prescribes ointments, and so on. Through our shahrian, ترجع, the same problem, he again gives another. Most of our patients have been sort of treated variously by general gynecologists or dermatologists. When they reach us in a stage usually more advanced than stage 1 or 2. Early biopsy of suspicious lesions is critical to diagnosis of malignant disease. If you see a lesion, send her to the oncologist and he will decide what to do about this lesion. Clinical features of vulval cancer are variable, and clinicians should have low threshold to recommend biopsy of concerning lesion. Variable, sometimes it's a polypoidal growth, sometimes it's ulcerative, sometimes it's just itching area, and becomes red and bleeds easily and so on. Then, physical examination of lymph nodes to determine metastatic disease is unreliable. When you see a lesion in the vulva, you try to palpate the lymph nodes, but this is not reliable because your fingers are not so sensitive to detect the inguinal glands. Aids to diagnosis of the inguinal glands, CT, MRI, or sometimes PET scan. But what we do, simple test, is either lymphoscintigraphy, اللي هي سوقفه العالم كله يوقفه, because it involves radioactive material, or methylene blue test. Methylene blue, injecting the tumor with methylene blue and wait for half an hour, and you see the discoloration in the inguinal glands, okay? But the positivity of this test not more than 85%. So what they have replaced is they introduce the ICG, indocyanine green, another dye, and they inject it in the tumor. هسه راح أراويكم صور مال ACG from our practice. They inject it and wait about 20 minutes and usually take a picture of these glands by a camera. Then, treatment key points. Primary treatment of vulval cancer involves radical surgery. Surgery is the best way of treating this because this is a squamous cell tumor. مثل ما أي مكان بالسكن, it's in the vulva. To excise the primary lesion with clinical margin of 1-2 centimeter. لازم excision يبعد عن the clinical margin by 2 centimeters so that you avoid any metastatic area involved in the lesion. Macroinvasion or stage 1 have a low risk of nodal metastasis. Stage 1 and some of stage 2, there is low incidence of nodal metastasis, inguinal nodal metastasis, may be managed by radical excision only. Ipsilateral lymphadenectomy is recommended for all invasive cell cancer, and bilateral lymphadenectomy is recommended for patients with lesions more than 2 centimeters, less than 2 centimeters from the midline. The more midline the tumor, the more aggressive invasion you see for both sides of the groins. Okay? So if we look at the lesion is less than 2 centimeters away from the midline, we have to look at both inguinal regions to see whether all this area is involved. Sentinel lymph node biopsy may identify positive nodes who require additional treatment and negative nodes who do not require full inguinal lymphadenectomy. If it is only on one side and one side lymph glands is involved, we may do hemivulvectomy and with gland dissection. المشكلة أنه هذه الarea is very important to women. And if you do massive surgery, you mutilate this area. And most women, they don't accept massive surgery because they look at themselves, you see themselves mutilated. And then you have to get the plastic surgeon to repair this mutilated area, and the success of this area is not very high by plastic surgery because you have to involve transferring some fat from areas nearby, higher bones, and transplant skin from the thigh. Main line of treatment. What are the main lines of treatment? Surgical, surgical, because this is the main line of treatment. People tried now, and they go for chemotherapeutic treatment of inguinal glands. But the success rate is not as much as surgical treatment. Excision of tumor, 1 or 2 free margin, 1 or 2 centimeters. Free margin, نقصد there's no invasion of the tumor beyond that margin.
Sorry, Dr. Samad, we are stuck in time. Another 2 minutes, please.
You have plenty of time this afternoon. كل شيء معك. بدينا من وقت خلي أكمل. Extended vulvectomy and gland dissection. This is the second stage if the tumor is central or the glands is involved in one area of the glands. There are more than 2 glands involved or lymphovascular space is invaded. Radical vulvectomy and gland dissection by the way operation. شرحت لكم الواي operation. Prognosis مالها is better than you do local excision, but it's a mutilating operation with a lot of complication, post-operative complication. Lymph gland depends on size and site of the tumor, and the next stage is exentration. We very rarely do exentration because this is for stage 3 and 4, which is premortal stages. كمل عيني. All right, treatment. Treatment, principally radical local excision is recommended with the aim to obtain histological tumor-free margins. هذا الهدف مالنا. أنت راح تدفعني أنه أطفر أشياء. زين. Next slide. Now we come to the groins. This is very important. In the 70s, Stanley Way, when he started operating on this, recognized that groin invasion changes the prognosis and the survival of these patients. Groin treatment should be performed for tumor T1 method measurement by the invasion according to the 8th version of T&M classification. هاي مشاركتكم. Surgical bilateral evaluation should be performed for non-lateralized tumors, medial tumor less than 1 centimeter. For unifocal tumors more than 4, إذا tumor جبتوا أول مرة more than 4 centimeters, you must assess the inguinal glands. لأن invasion in these tumors is more than 60%. The bigger the size of the tumor at the beginning, less than 2 centimeters, معناته it's unlikely has gone, it's only 4% that goes into the inguinal glands. من يصير 4 يصير 60% يروح للinguinal glands. So size of the tumor is a recognition for invasion of the tumor. When lymphadenectomy is indicated, superficial and deep femoral nodes should be removed. Lymphadenectomy is a very important procedure. نفتح عن الانguinal area and we go for the cloakwort gland. Cloakwort gland هي اللي كل شيء يترشح بيها. Study of the lymphatics of the vulva, they have found that all the vulval lymph drainage goes to the cloakwort gland. The cloakwort هي الحاضنة, الiliofemoral gland, lies on the medial side of the long saphenous vein. Dissecting it مو صعب, but it's rather critical. But we do a lot of this, and sometimes if it's injured or has gone into the vein, we ligate the long saphenous vein. امشي بالعجل خلينا نمشي. All right. This is what I call ICG dye. ICG dye injection, okay? And you put the infrared camera and picks up. These are tumor tissues. They all want tumor tissues of this dye. هذا دا ينطينا هسه الآن about 91% positivity of invasion of the tumor. هسه they are recommending to do both methylene blue and this dye. And they found that the positivity of the tumor spread is about 97% if you do both procedures. You inject this one side and you inject this one the other side. امشي بعد اركض شوية. Proposed planning for surgical treatment. حكينا عليها. Tumor size, age of the patient, spread, inguinal spread, and compliance. Compliance is very important. Is the patient young? Is the patient old? Does she accept this mutilating operation? And so on. واحنا عندنا وحده هذه dermatopyrosarcoma protuberance اشتغلناها سويناها vulvectomy and gland dissection. جتي ورا 9 أشهر حامل. They delivered her baby recently. يعني داخله بالستاتستيك راح طلعها. امشي بعد. وين؟ Okay. Skip this. Too much for them. Skip the other one. امشي. هاي همين skip it. Okay. Recommendations. هاي مهمة. Post-operative radiotherapy to the vulva. When do we do post-operative chemoradiation? Again, surgical removal is much better than chemoradiation. Chemoradiation has the disadvantage of bone osteoporosis, and many of these patients will have bone fracture, femoral neck of the femoral bone fractures spontaneously because X-rays weakens the bone, okay? Excision margins of the primary tumor, rather surgical, and for patients we use for patients who are not tolerant for further surgeries. Post-operative radiotherapy to the inguinofemoral region, we have to see the sentient lymph node metastasis. If it's more than 2 millimeters and isolated tumor cells can be treated post-operatively by radiotherapy, a safe alternative to iliofemoral lymphadenectomy. كبار بالعمر عمره 80 سنة and so on ما تتحمل iliofemoral lymphadenectomy. الدروباك بالiliofemoral lymphadenectomy is leg edema, chronic leg edema. تسوي العملية تجي ورا شهرين هاي كلها edematis and you don't know what to do for it. There's no treatment for it. وراها امشي يلا خلينا نختصر. اوكي نحكي على الميلانوما. Melanoma of the vulva, you just remove, you do local excision. There is no place for inguinal treatment because it's an aggressive tumor. By the time it is diagnosed, the tumor has gone to the bloodstream and gone somewhere else. You do a PET scan to see where the melanoma has reached. من زمان كنا نشوف melanotic melanoma. Melanotic melanoma, you don't recognize the lesion because it is white. You look at it, you think it's either it's excoriating lesion, skin lesion. You don't consider that this is a melanoma. And usually by the dermatologist, treated by some creams and steroids and so on, until it grows and becomes a polypoidal growth, then it is referred to the oncologist. Early metastasis is earlier than skin or ocular melanoma, more aggressive than skin or ocular melanoma. Regional lymph node metastasis not significant, mainly bloodstream metastasis. ما أريد أكمل أطفر بعد صعد. يلا ساعدون. Okay. ما أريد أفوت بالhistology of the melanoma. It's too much for you. The nodule, the acral, the types of melanoma which are more active than the simple ordinary melanoma. امشي بعد. Okay. Now results of cases treated since we established the fellowship, which is now about 5.5 years. We have seen, هسه قبل ما أسافر قبل ما أجي I dealt with 2 cases, but I did not include them in the statistics because it's just an early cases. Over about 59 cases of vulvar carcinoma attended our gynecological clinic in different groups. Stage, histopathology, different lines of treatment and different outcomes. 37 cases were 60 years old. So 60 and above is the peak incidence of carcinoma of the vulva. 14 were 50 to 60. 5 cases were 40 to 50 years. In my days, in the old days, I rarely see a patient between 40 and 50. But now we are seeing younger patients. ليش? Because HPV infection is spreading. Iraqis قام يسافرون, they go outside, they enjoy themselves, they come back and transfer the infection to their wives. عندنا وحدة unfortunately died. She married at 15 years. By the age of 17 years, she developed carcinoma of the vulva. And this is an unstratified carcinoma typical of the HPV infection. بعدين she ماتت. We did vulvectomy, slidات لوروبكميا, very ugly, repeated surgeries until she died. 1 case 40 years and 2 cases 20 years. 2 cases 20 years. أنا over 40 years, صار لي 50 سنة بالمدينة. ما شايف younger patients than 40 years. هسه recently in the last 4 years I have seen 2 cases 20 years old. 20 years old. هذول both are HPV infection. HPV infection transferred by the husband. رياجينهم سافروا فتح السفر ما شاء الله عليهم العراقيين hypersexual يسافرون برا يتوسون طيني بعد سلايد واحد. اوكي نحكي هسه stage 1 اوكي 19 1A and 3 1B stage 1 19 1A3 1B 18. So we always see them rather a bit late. 18 وحدة 1B. 1B means that there is a possibility of 1/3 of them there's a metastatic tumor in the inguinal area. Stage 2 6. Stage 3 12. زين وstage 4 20. if you mix stage 3 و 4 32 وحدة in advanced disease. فهذول they are doomed. Their prognosis is bad. Survival is not more than 2 years. Okay? With management, recurrence, حسبنا 4 years management in this regime. Recurrence occurred in 8 cases over 4 years. Histology, 53 cases, squamous cell carcinoma, 1 melanoma, 1 bartholin, 1 dermatofibrosarcoma protuberance اللي هاي حبلت وجابت. قبل ايش قد جابت رشا ما ادري قبل 2 years. she's still alive, she attends. وبس عجيبة she had a radical vulvectomy بس مع هذا حبلت. احنا we reported this in the British Journal because this is the second dermatofibrosarcoma case that conceived and delivered in the world, second one in the world. اعطيهم المقالة اعطيهم اياه زين. وهسه treatment flow chart لا صعب عليهم هذا treatment flow chart. Thank you.
أنا وداد العبيدي consultant gynae obstetric. صار لي بالإمارات حوالي 23 سنة. هاي الخيمة العلمية اللي جمعتنا الإمارات الحبيبة. أريد أقدم شكري وامتناني جمعة العراق والعراقيين والعلم العراق والعلماء العراقيين تحت هذه الخيمة الجميلة. وأشكر الكادر اللي اشتغل بكل دؤب وبكل حرص واشتغلوا مثل خلية النحل. أنا كنت من بعيد ألاحظ هذا. فألف شكر مليون شكر. وأكرر شكري للرئيسة الدكتورة مريم مطر اللي كانت تعمل من وراء الستار، تعمل كالجندي المجهول. أكرر شكري وتقديري. ما أريد أطول بالكلام لأنه الوقت ضاق. I want to invite Dr. Ghada Salman, consultant gynecology, fellowship of the Iraqi Commission for Medical Specialization, certificate of the Arab Board for the higher specialization of obstetric and gynae. Now she is working in University College of London, UCL Hospital. Her presentation will be an innovative approach in gynecology care. Please, Dr. Ghada.
Thank you very much. Good afternoon, everyone. Thank you very much for the chair and the scientific committee for the kind invitation. It's my pleasure to be here again in UAE and to be present with my friends, colleagues, and my professors from Iraq, Dr. Sarmat Khunda, and from UK, Dr. Mohammed Samarai, who I've been trained with, and I've learned a lot and gained a lot of knowledge, and I'm very grateful for that. I still remember, Dr. Sarmat, the days when I used to assist you doing these vulval cases, and I haven't seen such an amazing surgery again. So thank you very much. My talk today is about innovative approach in gynecological care in line with the conference title. So I'm going to go very quickly through the topics. Obviously, I have no conflict of interest to declare, and it is really difficult to talk about all of the innovation in gynecology in 15 minutes. However, I'll try my best to touch very quickly on each point. And obviously, when we talk about gynecology, it's not only about surgery, it's about everything, starting from diagnosis to surgery to collaborative care and to inclusive care. So if we start with advancement in imaging and diagnostic, obviously the high resolution ultrasound, the advanced MRI, and the new techniques that have been developed are all very valuable in patient care and providing excellence in gynecology. As you are all aware, ultrasound has been around since very long time, started in 1957 when we had this big, huge machine in the basement, and until up to now, with the continuous development when we see these new sophisticated machines that are in every clinic and in every department. But it doesn't stop here. Obviously, more advancement was created all the way, including 3-dimension, 4-dimension, where we capture the 3-dimension images of the organ, providing details, view, and with the 4D capture even more in the forms of videos, where we can see live images and dynamic images. Obviously, it's a continuous evolution, and we can see now beautiful pictures of 3D and 4D of lesions, where before we could see only a grayscale ultrasound, and now we can see this beautiful, almost real-life picture of a mass with the inside of it very clear to everybody. That we can see these pictures will be able to tell with some experience whether we are dealing with benign, with malignancy, what type of cyst, and what we need to do for these patients. That goes again for early pregnancy, and again we can see now beautiful pictures of early pregnancy, 3D, 4D, where we can see the details very clearly of the inside of a very tiny embryo. You can see the brain, the gut, the limbs, and we can actually diagnose and counsel these patients early in pregnancy for any anomalies or abnormalities before they advance to later stage when it becomes very traumatic. Urogynecology, again, so it's everywhere. This is some of my pictures, my patients, where we can see very nice pictures of mesh on 3D and 4D imaging, and especially now with the very hot topic of mesh, we can diagnose, we can treat, and we can benefit these women from just using this advanced technology method to give them the right diagnosis. Same with reproductive medicine. Again, some of my images from detecting uterine anomalies, where you can see very clearly that these women have uterine anomaly that can be diagnosed very easily now on the new advancement in technology. Same if we do follicular counting, where we can very easily put some marcation on these follicles, and the app will do all the counting for us. We'll put it in a colorful way where the patient can see very clearly, and you can minimize the time used for counting these follicles. Similar with hycosi, where you see the tubes beautifully on 3D hycosi, and you can assure the woman that these tubes are open or patent, rather than subjecting them to X-ray or laparoscopy. So advancement in diagnosis is crucial in gynecology. Doppler ultrasound is another part that's been developed and is continuing to develop, where we can assess the uterine blood flow and we can assess the vascularity of gynecological lesion, and that will give us even more information. And what is very new now, because obviously Doppler has been around for a long time, is the new super microvascular imaging, where it expands the range of visible blood vessels, where we can see these tiny blood vessels that we couldn't see before. And for us here who do oncology, we know that it's all about new vascularization, where we can see now these new vessels that we are able to see early on, and we can give the diagnosis, and therefore we can offer the treatment early on in the care. Something new as well that's been used in other parts of care, but we are now using it slightly more in gynecology and developing it, is elastography. So what is elastography? Elastography is an ultrasound technique that measures the stiffness of the tissue. So it is based on the difference in elasticity of the various tissues, so that we have different tissues in the body, some are soft, some are hard. And how we can assess that is by eliciting some pressure from the ultrasound probe, if you see here, and that will cause tissue displacement, and that will transfer to color-coded, as you see here, chart, with the most hard part display as dark purple or blue, while the soft, like bowel, will transfer as red. So how this is important in gynecology? This is a very clear example of how we can differentiate between different parts of the lesion. For example, when there is difficulty in assessing which part is which, such as in adenomyosis, you can see that the endometrium is soft, so it looks red, while the fibroid is hard, looks blue, and the rest in between, like adenomyosis, will be green. So that will give us more information, especially if we are not confident in saying what it is on 2D or on a grayscale ultrasound. That will add extra information for us. Another new advancement is the combination of 2 or 3 different imaging modalities, such as this smart fusion, where it combines the CT scan with a live ultrasound, and obviously we will get the benefit of both imaging at the same time. We'll be displaced at the same time, and that will be helpful for us to locate hard-to-find lesions, but also in the continuous assessment of patient for follow-ups to reduce the cost and the radiation. So obviously all these advancements are really important in diagnosing early conditions. Something very new as well that combines ultrasound with endoscopic view, which is called fly-through. I don't know if you heard of it yet, but this is a virtually travel image through an organ via ultrasound that will transfer to become a real-life view of the image. And that's what we see on fly-through technology, and that's what we see on endoscopy. So it actually reflects a very similar picture or view of what we're going to see by endoscopy. And definitely that will help physician counsel the woman and treat in the right way. And now, more recently, we have the mobile ultrasound. So we have developed from these big machines to a tiny portable handheld machine. And it is now on the market, okay? It can be used to connect to mobile devices, to iPads, to iPhones, to tablets, and obviously they have the support from the iPhones and other mobiles. Again, they are very easy to use. It can be done, the surgeon or the physician can put it in their pocket. They go see the patient. They take these portable machines out, scan the patient. They have a built-in battery, wireless wireless charging, 2 hours of scanning, no need for multiple probe, just one probe that provides everything. Obviously, it is solid, portable, and it is affordable. It can be used in different applications, and obstetrics, one of them. Gynecology still not as much, because obviously it's an external ultrasound, while with gyne we need mainly internal ones, but it can be used in so many other conditions or specialties. Why it's important? Obviously because it enhances patient experience by giving an early diagnosis, on-site diagnosis, and obviously treatment. If we come to gynecological surgery, my colleagues already touched a lot on robotic, but it's minimal access surgery and robot in gynecology, similar to other specialties. And obviously, the introduction of this minimally invasive technique has already started giving the gynecological surgery an enhanced patient care. But obviously, the recent advancement in surgical technologies with robotic assisted have even revolutionized that even more. So the introduction of the robot with the use of the robotic arms, the surgeon can obviously execute delicate maneuvers that is difficult to do manually. And obviously that will enhance patient care. So it has transformed gynecological practice. It has provided the surgeon with an enhanced visualization, dexterity, and that all improved to surgical outcome, patient satisfaction, improved recovery, minimal access surgery, so it leads to quicker recovery time, decreased post-operative complications, great effectiveness in performing complex surgeries, and is now and more used not only in oncology, endometriosis, but even in benign gynecology. If we are talking about more minimal invasive, it's not only about surgical, but actually we can use ultrasound in treating different conditions such as fibroid, something called HIFU, which is the focused ultrasound surgery. It is a non-invasive therapy that uses focused ultrasound waves to thermally ablate part of a tissue. So it uses the ultrasound energy to sonicate the lesion, such as fibroid. Obviously, it will produce a high power or a high heat, reaches to 78 degrees, and that obviously will destroy the lesion that we want to destroy, such as fibroids. And that can be done under using ultrasound or MRI focused. And again, why it's important, because it's not invasive, it's not surgical, less risk, no radiation, quick recovery, and can be used in so many conditions such as gynecological and non-gynecological, for example, metastasis to the bone. Fibroid ablation is another new technique that uses radiofrequency ablation in a minimally invasive procedure. So we use radiofrequency to generate heat rather than ultrasound. And that, again, can be used using something very simple, like a tiny probe that goes into the uterus or through the abdomen and, or vaginally. And then we insert it into the fibroid, and then we apply this radiofrequency. We ablate the fibroids, we shrink them, and improve symptoms without any big surgery. So this is, again, another new innovation in treatment. Telemedicine, again, we have not to forget that now telemedicine is big. We are using it in UK, and it was my privilege to be part of developing this in another country, which was Egypt. And telemedicine is emerged as a critical rule, really, because it increases the access of patients to gynecological care. So it allows for remote consultation, reducing barrier to patients who have difficulty in transportation, they are old, they can't afford it in underprivileged area. So it actually expands
please, 3 minutes.
Thank you. It expands the option of care for the patients. So it will allow for continuous engagement. They don't need to come physically to see you. So I'm sitting here in this country, and I can give follow-up to my patients in the UK if I need to, if there is anything urgent going on. And also what is now very important is that we have to treat each patient in an individualized care. So not one thing fits all.
we have to be very, very personalized. So something like advanced biomarkers, taking a clear patient history, putting everything together to make a specific plan to treat this patient. And that will not only will be effective, but because the patient will know that it is a specialized treatment for them, they will engage more and they will adhere to it more. One example of personalized treatment is the next generation sequencing in gynecology oncology, where it is, as we are now in this conference talking about genes and genetics, is about how we can enable the profile of genes to know what conditions these patients have and how we can treat them, and if it is she is prone to this condition or not, or that. And now we have this by doing a very simple test of DNA. They can check, for example, what condition you are prone to have and how you can prevent it. So again, something very new, but very effective. Hormone therapy adjustment, and this is a big topic, and my colleagues, Dr. Ali and Dr. Sadoun, will be talking about contraception and about HRT, so I'm not going to talk a lot about it, but actually is about exploring what hormone variability available and individualize the care to that patient, especially with the new advertisement or availability of bioengineered hormones. What is innovative approach to fertility? I'm just going to quickly touch on it, and that is new techniques in oocyte freezing, in cryopreservation, and how we are now offering more and more ovarian or egg or follicle freezing for women who will open, obviously, their chance for conception maybe later in life because maybe they are not ready or because of other medical conditions such as oncology treatment. So again, that's part of a very big fertility advertisement. Now, integration and approach to women's health, again, is very important because it's not only about the body, it's about the brain, about the mind, about the soul. So we have to look into all of that. And now when we speak to the patient, we have to look into a holistic approach. We need to explore other options rather than just medicine. We talk about other techniques such as yoga, meditation, relaxation, stress reduction, because all of that, if we put them together, that will treat the physical symptoms effectively, because the patient, if she is mentally better, then she will improve quicker. So again, this is something that we always think about, and we always do a multidisciplinary approach when we see patients. Not to forget the role of nutrition in gynecological care. As we know now, there's a lot of conditions that if we look to the basis of it is all related to what we eat, about our diet, about our nutrition, including polycystic ovaries, endometriosis, fibroids. So all of these are really back to what we eat. So we have to always educate and look and think about what diet patient is eating and how we can advise with the good or correct nutrition. We have to remember, we have always to work together with people who have got the knowledge about technology. So together, in collaboration, we can benefit our patients. AI, AR, robotics, they are all important, but how did they develop? They started by working together between surgeons and between engineers who've got the knowledge to develop. The engineers will have the information about technology, while the surgeons or the physician have the information about the clinical care. And together, they can put a tool that will be useful to the surgeon, to the patient, and obviously for the future. So what's the next step? Okay, it's all about AI and AR. Okay, so artificial intelligence, AI, enables the computer application to mimic human-like intelligence and can resolve problems such as predictions and provide solution. While the AR is the augmented reality, it enhances a real-world object on a virtual platform to create an immersive environment. So the AI focuses on simulating human intelligence, while the AR enhances a real-world experience by overlaying digital information onto our surroundings. So these are the future. This is what's now going on in the world. How we can use that? So obviously we can use it in diagnosis, because when we apply artificial intelligence in diagnosis, that will even further improve our diagnosis, because these AI, they will look into all the previous data, they will analyze it, and then they will give us a learning model, because it recognizes the pattern, rather than asking the expert.
Thank you, Dr. Ghada.
Yeah, that's last slide. Rather than asking the expert, we will ask the AI and we'll give you the right diagnosis immediately, which definitely will help develop and improve patient care. And finally, it's in surgery. So AI in gynecological endoscopy, it obviously helps surgical procedure by enhancing the precision, and they identify critical anatomical structure, which can improve surgical efficiency, safety, and improve patient care. That will help us all, as well as AR in improving patient care. Why we need AR? AR can help training, can provide a real-life scenario for trainer to train people, and also for the trainee to do the surgery in real life. That will also allow a low-risk rehearsal of surgical procedure, and obviously will improve patient care. And that's the end of my talk. Thank you very much.
Well, thank you very much for the introduction, and assalamu alaikum, and thank you to the organizing committee for accepting my contribution. I work in London at Guy's and St Thomas's, so we're opposite Big Ben. So when you visit London, يعني ما تقدرون تضيعوني لأنه the hospital is just opposite Big Ben. But I love Dubai. I'm usually here at least once a year to take part in meetings. You'll see that at the bottom is my email, and the reason why I put my email there is because I don't think I will do the whole topic in the 12 minutes. So I've told the chairs to give me a 3-minute warning, and because there is an advert at the end of this, so if you have any questions or if you want more information or whatever, you can contact me by email. We're celebrating Iraqi women, and you can see at the top row, there are the icons of Iraq, as far as I'm concerned, but the bottom row are the backbone of Iraq society. And I think it is very important that we appreciate the contribution that women make to our society, and therefore give them the absolute best quality treatment. I have no conflict of interest as far as this presentation, but I use this slide to just tell you a couple of things. So the idea is if we, I mean, this conference is about innovation in technology, but there are innovations in communication. And people like me who work in sexual reproductive health, it's all about communication with patients, with their partners, with their family, with their society, and interprofessional communication. So the idea is to move our patients from this state to this state, to communicate the right message. So here it says, face mask is not necessary, please use a condom, and look at the number of people who are on this track. But also to highlight that contraception has been a world saver. Without contraception over the past 50 years, the planet we live on will have had millions and millions and millions more people draining our resources. I'm going to skip this slide. This is essentially a slide that gives you all the methods of contraception. There are lots of methods of contraception. I usually use this for the students to test them. And I just wanted to highlight one thing, because you do female sterilization in this part of the world, that now the method of sterilization is not tubal ligation, but it is removing the tube. It's tubectomy, because the tube is a source for initiating ovarian cancer, and by doing tubectomy, you reduce that risk. Okay, so Contraception is actually very good for you. This is a complicated slide. At the top, you'll see that spacing pregnancies have benefits just because you are spacing pregnancies. The bit which is at the bottom there are the deaths that happen worldwide during pregnancy or labor. And you can see in 1980, we nearly had, I mean, this is what is recorded. There are lots of unrecorded deaths. Nearly lose about 500,000 women per year in pregnancy. But if you look at 2021 at the edge there, we're still about 250,000 deaths per year because of pregnancy. So preventing pregnancy or timing pregnancy, spacing pregnancy makes a difference. The second lot is the non-contraceptive benefits that apply to everybody. Remember, people who use contraception will get all these benefits. When you talk about the risks are limited to a small number of people who are at risk. And the important thing is the reduction in cancer risk. And then you can see the list of therapeutic roles. We use contraception to preserve fertility, to manage polycystic ovaries, premenstrual syndrome, in the perimenopause, acne, heavy menstrual bleeding, and sexual dysfunction. And the other two slides, as you know, everybody in the talks today has shown very high-tech images. So I'm using some cartoons, and I'm going to use a bit of art for my talk. So this is a cartoon where the woman is being told about a job. It says, we're looking to someone who can do the work of 2 men. And the woman is saying, 2 men? This must be part-time. I usually do the work of about 6 men every day in my work. I think the communication bit is the 2 bananas. You can see that the front banana looks terribly worried. The back banana looks terribly pleased. And there is obviously an issue about communication between these 2 bananas. So it is very important that we are aware of that. We look at combined hormonal contraceptives which have massively long benefits. So if using the pill or the patch or the combined vaginal ring or the combined injectable, which is available in South America, you reduce bleeding, you therefore reduce anemia. 80% of women in the MENA region go into pregnancy anemic, which affects them and affects their children, and dysmenorrhea. The net effect of combined hormonal methods on the genitourinary tract is progestogenic, so cervical mucus becomes thick. It prevents bugs going to the tube and causing pelvic inflammatory disease. A lot of people think that the pill increases the risk of fibroid. It reduces that. A lot of them think that it increases the risk of benign breast disease. It actually reduces that. Time magazine and many other experts think that, for instance, the pill, which is now about 70 years old, was one of the greatest innovations of the 20th century. Reduction in functional ovarian cysts and reduction in hospital admissions, and we've mentioned all the other benefits. There are also now much easier ways of using contraception. For instance, we now suggest to women that they don't take the 7-day break between packets. We say that the normal state of affairs is a state of ovarian suppression. You don't need the 7-day break. The 7-day break was introduced by the people who invented the pill because they were hoping that the Pope will support the introduction of hormonal contraception. And as a matter of fact, that didn't happen. Natural estrogen pills and low-dose pills can be used to the age of 50, so age is not a contraindication. Duration of use is not a risk, so a woman who comes to you and says, I've been using this method for the past 5 years, it must be damaging my body somehow. Actually, the risk at the use of 5 years, or if she uses 10 years or 15 years, is exactly the same. You can quick start any method of contraception anytime in the cycle, as long as you exclude a pregnancy or a pregnancy risk. Broad-spectrum antibiotics are no longer a problem as far as efficacy of the pill. And we have a number of natural pills. We have Clara, which has estradiol valerate. We have Zoli, which has estradiol. And we now have this new pill called, which has estetrol, which is the fourth natural estrogen. It's a fetal estrogen. It's an estrogen that the baby inside the uterus produces from its liver. And it's been discovered, this Felucci actually discovered it about 50 years ago. And they spent about 10, 15 years thinking, why does a fetus produce an estrogen? And they think it actually improves brain development in utero. And indeed, there is a lot of research on this estrogen, looking at it. It's already available as a contraceptive called Drovelis in Europe, and is going to be available within an HRT preparation. I think later on this year. I declare an interest. I'm on the advisory board for this pill, but there is also a lot of interest in it in the sense that it probably protects against breast cancer, one. It helps healing, and it probably helps brain development. Just to, again, emphasize that amenorrhea is now the natural state to be in. This is an important slide. It looks at the non-contraceptive benefits, which you, me, the patient may not know about unless we tell them about. This is the RCGP study, one of the biggest studies in the world. It was started in 1970. It's been going on until now, and it has taken a cohort of women who have used the pill over that period of nearly 60 years. So it has nearly 1 million woman years of data, and this is one of their reports in 2017. Taking the pill reduces the risk of colon cancer by 20%. That's proven, no dispute about it. 34% reduction in endometrial cancer, 33% reduction in ovarian cancer, no dispute about all of these. 26% reduction in that study in lymphatic and hematological cancers, but we don't have evidence to support this as a definite advantage. Progesterone-only pill is very safe, is now sold over the counter in most of Europe and in the US, and therefore it's as easy, put it in the water. You don't need to worry about it. It has no estrogen. It also is a good bridging contraceptive. So during COVID, if a woman rang my office and said, I have a coil, I have an IUD, I want it changed, and I have no clinic open for her, I will send her a prescription, or I send her the product, a progesterone-only pill. I say, use these, and I'll give you an appointment maybe in 2 months' time or something like that. It's good in breastfeeding, and there are now 2 pills, desogestrel and drospirenone pills, which inhibit ovulation. And as a matter of fact, the drospirenone pill, this is called the Slinda in Europe, is now one of the fastest selling pills in France, in Germany, and it is really, really doing well in the US. The US have no progesterone-only pills except this one. And a recent Cochrane review thinks that the efficacy of the progesterone-only pill, especially with these pills that inhibit ovulation, is similar to the combined pill. So it is not the sort of second best to the combined pill. It's becoming a mainstream #1 method. I'm not going to, how much have I got now?
You have 3 minutes to go.
3 minutes, okay, so you can tell so I'm going to skip this. Intrauterine contraception, again, has a number of advantages. Obviously, if you look at the top of this slide, these 2 devices, the hormonal and the copper devices, are the most effective devices of contraception. And as a matter of fact, the hormone device is more effective than female sterilization. Copper IUDs reduce endometrial cancer through phagocytosis and reducing mitotic activity, and copper inhibits the estrogen receptors. Hormonal IUDs obviously reduce the risk even more because of endometrial suppression and can be used with combined menstrual hormonal therapy. Both IUDs reduce the risk of cervical cancer. People don't know that. This is the work from Barcelona and showing that there is a significant reduction in cervical cancer risk in IUD users because they think that the insertion of the IUD, the manipulation of the cervix, is trauma, it induces an immune response, and that immune response, as the cervix heals from the trauma, gets rid of the preliminary phases of cervical disease. But there is also evidence that both the copper and the hormone IUD reduce the risk of ovarian cancer, and you think that can't be a foreign body. But we think it may be because of the changes in the pH, in the fluids around the tube, for instance. Hormonal IUDs obviously inhibit ovulation, but the mechanism is under investigation. So the take-home messages, these are, again, my art or cartoon figures, is that counseling and communication is the essence of successful contraception. Science is progressing well in what is a mass population intervention. Remember, we talk about robotic surgery, the surgeon will say, well, I've done 60 cases of these. Well, here we're technically managing millions and millions and millions of women. Think outside the box. Most contraceptives are safe, and we don't need frequent checkups. And there you see, this is Faisal al-Abi. You can see, though this family looks a bit concerned, but at least they're sort of comfortable together. And this is what we use in the UK. If you use contraception, precision contraception, individualized healthcare, then the woman is happy, her husband is happy, the baby is happy, and her dog is happy. And this is my advert, so this is why I gave the email. I have worked throughout, and there are people here, Sa'doun, Ghada, and Ustad Sarmed, and Ali, who's just arrived, Ali Hamdani. They've all worked with us in initiating liaison between the Iraqi diaspora in the UK and the US and Iraq. And I go to Iraq frequently. I'll be there in May. So those for the few Iraqis from Baghdad, I'll be in Baghdad in May. So we may take these up. We, the diaspora people, continue to be لازقين لزقة بالنخلة. So these are all things that I have been approached about recently from diaspora, younger doctors who I've worked with before, who came from Iraq, who are keen to produce any of these things. We can, there's a group in Birmingham, we can offer family physician fellowships. There's a group in Emory University which do training for last year medical students and new graduates. We have done a lot of fellowships for more sort of mature doctors, setting standards and MDTs. We had the presentation about Kamadia and the committee that the Wazart al-Sahha has, but Iraq doesn't have a formally. آخر formally بالعراق سنة 1973 علاء العلوان سواها. And Iraq has been without a formally for both private practice and for the general hospital since that time. And we are offering to do that. We only need people who either advocate, encourage, take part, or help with the funding. Practical skills and standard setting. Nearly there. So I always say, we'll see you hopefully again. Keep the conversation going. It's all about communication. And من يسألون انتوا وين بإنجلترا احنا وين هنا المصايب مالتنا إلى آخره. I say, well, the moon I see, sorry, I need to go back. How do I go back? I go back this way. ماكو مون هنا, but this is Tower Bridge. My rooms are just near here in London Bridge, and this is a sunset that I sometimes see if I'm working in the evening. And I always say that the moon you see, this is Karbala, is the same moon that I see in London. And when we see the moon, we can make contact. Yeah, the same moon you see is the moon that I see. And we need to take up conversation. So I look at, you don't need to, I show it to medical students in Baghdad. كل ما أروح كل سنة أخذ مجموعة من medical students and they love it. كلهم كل التلفونات تطلع. But I'm also encouraging what is called the hackathon. I don't know how many people here know about hackathon. There is a trend definitely within undergraduate works in different places in the world, including the UK, of asking people to, if you have 6, 7 good medical students and you want them to do something, you say, okay, if you like each other, you like working with each other, this is a topic, go and hack it and produce something out of it. So one of the things I gave in the University of Baghdad when I was there in September, I said, well, look at, for instance, an electronic patient record. Electronics is what we are all aspire to. Just go together, hack, find where there are good electronic records, and produce something out of the hackathon. So this is an advert as well, and this is my last advert. This is an advert for the family. So we say, well, thank you very much for listening. Continue to make contraception a happy experience. And this is a painting من فنانة اسمها ليلى كوبا. I don't know, does anybody know who Leila Kuba is? Not really. She's an artist. She lives, her مرسم ببيروت. She's about 80 now. 2016 قالت أنا لازم أروح للأهوار. I need to أريد أرسم الأهوار. عمرها يعني 2016 I think she was 75, and this is القصب مال الأهوار, and this is supposed to be مشحوف. هي طبعا she's a modern artist, and it's a woman. This is a woman on the مشحوف. This is her vision of the woman on the مشحوف, and I find it very pleasing and very calm. Do you know how much this was sold for? Over $100,000. Okay, it's a fantastic picture. Thank you very much.
Thank you, Professor Ali, for this very informative lecture.
I'd like to invite Dr. Sami Sadoun, a group of Chief of Women Health Services in NMBC, and Consultant Gynae and Obstetric, and Associate Professor in Mohammed bin Rashid University. He is going to talk about refinding the pause, embracing a new era of menopause. Welcome, Dr.
Thank you very much for the kind introduction. Let me start with thanking the organizing committee and the scientific committee, my friend Manaf al-Hashimi, for the kind invitation. I'm giving a very difficult task, a challenging one, to finish the talk within 12 minutes. Promise I'll try my best. But also a few challenges. I'm following 3 distinguished speakers with 3 outstanding talks. So I'll try my best to keep it the same pace. But also I'm observed by 2 of my mentors sitting here. Please, can we have a round of applause to my 2 mentors, Professor Khunda and Dr. Mohammed Samarai from Baghdad and the UK. They taught us a lot, and we owe them a lot of things. And finally, I'm also observed by my wife here, so bear with me. Thank you, Dr. Ali Kubba, for setting the platform for my talk. I'm going to talk about a different stage of life in women's life. It's not working. Yeah, I have no conflict of interest to declare. And my objective is to try to find out why we are discussing the menopause today, why now, and let's talk about menopause hormonal therapy or HRT, what are the benefits and the risks. Let me start by looking into the past. Ancient Greek are the ones who defined the menopause, coming from the Meno and the poem, which is related to the cycle of the moon. And unfortunately, if you look at the Victorian era, they describe the woman during that, they connected the uterus with the brain, and they found that women are susceptible to insanity. So they described the period of the menopause is the period where you have to put women and lock them up, which is very unfortunate. Until 1970s, the menopause was defined as a psychological crisis that required treatment. This is all in the past. But let's look at the life expectancy and why we are discussing the menopause today. The differences between life expectancy between women and men is usually more and better in women's life, about 4.8 to 4.6 years. And if you look at the life expectancy between 2021 to 2050, we expect that women will live into the 80s and the 90s. And this is the life expectancy in, don't know why it's not working. Let's go back. No, stopped working.
Just keep pressing.
Yeah, let's go back. This is life expectancy in UAE, and unfortunately this is the period of the COVID, and this is between 2012 to 2022 or 21. Not very different when we talk about Iraq. Yeah, this is Iraq. This is the last census in Iraq with the life expectancy. You can see that women are living and men are living longer, but they spend most of, well, good part of their life during the menopause. This is the average age of menopause all over the country, and it's between the 47, 48 years. And that's why we are discussing this today. In quantifying that, in 2030, we will have around 1.2 billion women living during the menopause. About 85% of those women will be suffering from significant symptoms. And this is the definition of menopause, is when women stop their period for 1 year. I always question this one because we will come and talk about the period prior to the menopause, which has got more or less significant symptoms. As I mentioned, about 85% of those women will experience significant symptoms, and 25% of them are debilitating symptoms. And that's why we talk about the menopause. It's not the period or the time when they stop their period after 1 year, because it's all transitional. And the ovarian function and reserve decline gradually over years. And this is where the transitional period comes, when the ovarian reserve is going down, ovarian function going down. This is the estrogen level, and this is the FSH level. And this is a very important period we need to pay attention. If you look at the symptoms, they start from the early 40s in the form of vasomotor symptoms, and they develop gradually to waiting for a longer time. You end up having lots of long-term consequences, including the bone, the atherosclerosis, the coronary, the cardiac, all these symptoms. And if we look at the bone mineral density, the decline in the BMD in women is more significant than men, especially during that period. Hence, this is very important to pay attention. As I mentioned, they are living now nearly half of their life during that period with a lack of estrogen. Now let's talk about what we call it HRT, or menopausal hormonal therapy, and this is the journey of the HRT. The two important years or period is the 1940s, at the time of the discovery of the estrogen replacement therapy, and the 2002, when the WHI study, the Women Health Initiative study, came out, and they stopped and they put the warning about the use of the HRT and the breast cancer. Unfortunately, during that period, lots of women stopped taking the HRT, and we'll see now what's the impact of this study on the life of women in general. We need to remember that not all estrogens are the same, and this is very important. So please, when you discuss with the woman about the HRT, and they talk about the estrogens are different. There is the natural, there is the synthetic one, and also the progesterones are not the same. They have different progesterones with different effect. It depends on the binding to which receptor that which effect can be given. So you have all these effects of the progesterone depending on which receptor they are attached to. Now, I'll give you some studies. I know this is afternoon. I'm not going to be heavy with the data, but let's give a few studies about the impact or the effect of the HRT on women's health. So this is a study talking about the hormone replacement therapy with the vasomotor symptoms. We now accept that most of the HRTs are useful in improving these symptoms with the differences between different hormone replacement therapy. Talking about bone mineral density, this is comparing the placebo with different sequential hormone replacement therapy with different doses. Certainly, it's significantly better in improving the proximal femur bone mass. In the same study, they're looking into the intervertebral disc height. They found a significant improvement in that if you give the sequential. The same thing for the continuous combined HRT. So for both of them, there is an improvement in the bone mineral density, both in the femur and the intervertebral disc. What about the lipid profile? Again, I would like to apologize. This requires a few hours of discussion, but I'm trying to summarize it. And here we look into in this study looking at the HDL. We know that HDL is the good lipid for the body, and the LDL is the bad one. If we increase the HDL and reduce the LDL, that does improve the lipid profile. And in this study, comparing the placebo with the different doses of one of the hormone replacement therapy, significant improvement and increase in the HDL. And in this study, looking at the different lipid types, cholesterol, HDL, LDL, compare different hormone replacement therapy. What about safety? And this is what stopped women taking the hormone replacement therapy. And the first thing talking about endometrial safety, cancer, hyperplasia. This is a systematic review of 28 studies looking at the safety profile of the HRT. Of course, if you use estrogen alone in the presence of the uterus, you increase the chance of endometrial cancer. There is no doubt about that. There is a debate and question about whether you use combined or estrogen alone in a patient with a subtotal hysterectomy, but that's a different category. We can talk about it later. If we use continuous combined HRT, it's more protective than the sequential one. And they found some of the micronized progesterone increases the risk, including also the tibolone. They found that recently the digosterone reduces the risk of endometrial cancer. This is the Danish study talking about if you have a patient coming to your clinic with postmenopausal bleeding, if you categorize them into two groups, one using the HRT, the other one are not using the HRT, the group who are using the HRT have less risk or chance of diagnosing with endometrial cancer. Now, this is the biggest problem that we faced with the WHI study when everybody stopped and dropped the HRT. If you go out today with nothing from this talk, I would like to remember this slide, please. So, if we take a population in the UK aged between 50 to 59 years old, and we follow them for 5 years, there will be 23 cases of breast cancer every 1,000 women. That's the baseline in general. If you have a BMI, if those group has got BMI of more than 30, there will be additional 24 cases. If you drink alcohol 2 units or more per day, you have additional 5 cases. If you use combined hormone replacement therapy or combined contraceptions, you have an additional 4 cases. And if you smoke, additional 3 cases. But If you use estrogen alone, you have 4 fewer cases than the baseline. This is the baseline, 23 per 1,000 cases. And if you exercise, at least 2.5 hours moderate exercise per week, you reduce by 7 cases. So it is not about the HRT only. It's a combination of many factors, including the lifestyle. So it's similar to if you drive a good car, but you end with an accident, you blame the car. It's actually sometimes the driver with the poor skills they have. So we need to individualize what we tell our patients. What's the story we tell? So there is a huge difference between you give HRT to a woman who is of a normal BMI, exercising, doesn't drink alcohol, or doesn't smoke. The risk in those patients, in those women, significantly lower than the other group with just a BMI. Now look at this study. Sorry, this is the WHI study, the follow-up published 2020.
Dr. Salim, please, 5 minutes.
Yeah, we'll finish soon. So this is where we have the highest risk of breast cancer, and this is where you have, if you use the estrogen alone, you have the lowest chance of breast cancer in that study. This is a study in Pakistan looking at what are the risk factors of breast cancer. And you found out that using hormone replacement therapy, the risk is less than 5%. But if you look at other risk factors, significantly higher than the HRT itself. Similarly, in China, reproductive factors are significantly higher chance or risk of developing breast cancer than using HRT or contraceptions. The choice of progesterone in this Finnish cohort study 2009 makes the difference between using different progesterone in combination in the HRT makes the difference in the breast cancer risk. We know now it's not the estrogen to blame for the breast cancer. It is progesterone, but different types of progesterone gives different risks to the breast cancer. Looking at the British Menopause Society with their statements and guideline and recommendation is that even in a high-risk population of breast cancer, using the hormone replacement therapy for a period of time is the benefits exceeds the potential risks of breast cancer. And also talking about the hormone progesterone, dydrogesterone probably has got the lowest chance of breast cancer than other progesterones. VTE risk, we know that if you use estrogen alone, you increase the chance of venous thromboembolism. If you use, and some of the combined has got less risk than the estrogen alone. And this is using different types, and you can tell that transdermal hormone replacement therapy has got lowest chance of venous thromboembolism than the oral one. Cardiovascular risks, we all know that cardiovascular diseases and death from cardiovascular diseases increases significantly in women after the age of 50, and it is linked with the menopause status. So if you take the same age group here, same age group, but menopaused and not menopaused, the risk of death from cardiovascular disease is significant in the menopausal group. And if you give hormone replacement therapy within 10 years of the menopause, you improve the chance significantly and reducing the risk of cardiovascular disease. However, if you start the hormone replacement therapy after 10 years of the menopause, there is some benefit, but there is no harm at all for the cardiovascular disease. What international societies are telling us, these are all different menopausal societies all over the world. I selected different keywords in their recommendations. So effective, it's effective. That's HRT, talking about it's a first-line treatment. Must be tailored, must be individualized. All the guidelines saying exactly the same. And talking about the appropriate dose, appropriate use, what's the duration, and the risks versus the benefits. With this, I would like to conclude with few take-home messages. WHI study was in 2002. It's more than 20 years old. We need to rethink about what we tell our patients, and are we really giving them the right advice? Are we allowing them to make the informed choice? We have to do that. Not all estrogens are the same. Not all progesterones are the same. So don't paint all the HRTs with the same brush. And final message, the right combination unlocks the remarkable possibilities. Ladies and gentlemen, let me finish with saying aging is normal, but suffering is not. Thank you very much.
Thank you very much, Dr.
12 minutes.
Sadoun, for nice presentation. Thank you.